reimbursement. To moderate this session, we welcome Adair Newhall, Principal of Greenspring Associates.
Thank you. Jack, really appreciate the intro and really excited to be in front of you all today. We will be talking about primary care, but let me introduce the people to my left. Dr. Adam Myers, he is the Chief of Population Health at the Cleveland Clinic. Also, he runs Cleveland Clinic Community Care. And to my right, we have the CEO of Paladina Health, my good friend Chris Miller as well. So thank you both for making it here today. I am super excited, I think, to have this event here. We're off the buzz of Ohio State beating Northwestern, so hopefully the Clevelanders are feeling good. I also personally love cosmetics, so after this event, I will make my way down to the conference center. I suffer from an affliction called pale skin, and we'll look for a red hue. Let's start with Dr. Myers, and then we'll move on to Chris. But Dr. Myers, if I were to read your bio, you run the ambulatory practices, the community internal medicine, geriatrics, pediatrics, family medicine, hospital medicine. Is there anything you don't run at the Cleveland Clinic?
Oh, there's a lot that I don't run. Yes,
okay.
Absolutely.
Prior to that, you were CMO and COO of the Texas Health Physicians Group, 1,000-member organization, 275 clinics. What of that experience prepared you for what you are now tasked with here at Cleveland Clinic?
Well, I think the part of what I learned was that the complexity of interfacing between the community practices and the academic practices at UT Southwestern. We had a clinically integrated network there that was a partnership between the medical school and Texas Health Resources. And that partnership was fruitful and strong, but it was a delicate balance, blending town and gown, which was interesting because each brings significant expertise to the table that the other may not have quite as strongly. So that was one part of it. But the other part of it was just dealing with so many different geographic locations. 275 locations was interesting, and the level of complexity from the P&L and the management structure of that was good. But it really boiled down, though, to focusing on what connects all those things together. And the things that connect those things was a desire, just a consistent desire to optimize the outcomes for the patients and to optimize the experience for the patients and the caregivers. That crossed the whole spectrum. And when you find that commonality, that's what I learned and that's what I bring here is the desire to do that.
Okay. I imagine when you joined the clinic, it made you become much more international and global in perspective. And so you have operations in Abu Dhabi and also in China. Different cultural norms, different ways to treat patients. What have you brought from your experiences and now run on an international level here at the Cleveland Clinic?
Sure, we currently have location in Abu Dhabi. That's our most established international location, and it's a full-service hospital. We also have a wellness and sports medicine center in Canada, in Toronto, as well as a neurological institute out in Las Vegas. But we also now are working toward building, in a joint venture approach, a hospital in China in much the same way that the Abu Dhabi venture is there. So, you know, it is, the Cleveland Clinic has a unique ability to adapt its strength, its care model, and its uniformity and apply that in different settings and in different geographies and cultures. And I think that's really what we bring to the international setting in that regard. So it's not just putting our sign on a shingle in those locations, it's actually changing the way that care is provided in those locations.
And have you had to break through any cultural norms? Has there been anything that you can duplicate what you're doing here in the U.S. and try to wash, rinse, repeat and do in the internet?
Yeah, I mean, it is a bit of a wash, rinse, repeat, but at the same time, for instance, in China right now, there is very little in the way of what we would all view as standard primary care. In that location, people will travel hours, if not days, to get to where they can receive primary care, then wait hours, 4 hours for an appointment that then lasts less than a minute. And that's not sort of the style of primary care that we would really push and purport as being the most fruitful. So changing that cultural norm and the service norm into something that's different takes time, but they're very engaged with us in those conversations. And the hospital will be a full-service hospital with a lot of specialty emphasis, but surrounding that, in much the way that we're looking to surround our London hospital, which I did not mention, we just had the topping off ceremony for our London hospital, which is a full-service hospital that's going to be across the street from Buckingham Palace.
Oh.
It's right across
Prince
the
Harry's
street.
excited.
Yeah, it's very interesting, and that's scheduled to open up in February of 2021.
Brilliant. That's great. One thing, as I talked to Dr. Myers and Chris, that you find out is actually getting doctors to spend more time with their patients in the primary care setting, which has been dwindling over many years. But that emphasis of care and personalizing, and I think is what I hear you both doing more of. You also have the clinic is aggregating primary care into one operating unit,
Yes.
which falls under your lap in many different regions. So tell me what it's like what challenges do you face trying to get it under one umbrella?
Yeah, it has been interesting. Before I started, pediatrics was in a different place, medicine was in one place, family medicine was in a different place, geriatrics. And what they did was wisely, I think, decided to create an operating unit focused on population health and changing the way that care is provided across the continuum, as I like to describe it, from twinkle to wrinkle, from all ages, all locations. And so in doing so, they aggregated family medicine, general pediatrics, internal medicine, geriatrics, the post-acute physicians, as well as the hospitalists. So it's the full spectrum of primary care, because I view hospitalists in a way as being primary care physicians on the inpatient space. And so that's all aggregated now into one operating unit, and the concept is to share many of the approaches, no matter what age of patient that you're treating. And the approach is very team-based. We're embedding pharmacists into our practices, behavioral health social workers into our practices, nutritional support, and a variety of care navigation services into our respective practice locations, and really changing the way that standard primary care has been done, as well as remodeling the workday to where across all the disciplines, to where instead of depending solely on face-to-face encounters, there will be built-in time throughout the workday for virtual encounters, to reach out virtually to patients in such ways that were described in the earlier conversation. And then an additional aspect of what we do is we go into the patient's home. We have a division of the Cleveland Clinic called Care at Home, and that was also brought into Cleveland Clinic Community Care. And that's where we have nurse practitioners, physicians, and paramedics that are part of our organization and part of our group that go into the homes of the frail elderly patients and help them stay where they want to be. And we've had a lot of success in that regard as well, in keeping patients where they'd like to be.
Interestingly, what you're talking about is trying to keep the patients healthy, but outside of the primary care offices themselves.
Well, a face-to-face encounter in the traditional primary care visit is a desirable thing, but it's not always the desirable thing. And determining when that is the best thing from both the patient's perspective and the provider's perspective, and where that is the case, have the access be available where the patient needs it, not necessarily where we happen to typically be. And then, if it's a come to us, make that easy to do. But if it's a go to them or meet them where they are, make that also easy to accomplish and easy to navigate. So that's really what we're about.
Okay. Dr. Myers, I'm going to shift to Chris for a second, but I'm coming back to you in a little bit, so hang tight for me. Chris, you are a repeat entrepreneur, Trumpet Behavioral Health, and you also, before that, were at ResponseLink. These weren't necessarily in primary care, but what did those experiences help set you up when you now became the CEO of Paladino?
Yeah, good question. So, I think the underlying theme of what I've tried to achieve with my healthcare background is to build businesses that are focused on mission and values. I'm lucky enough to be from Cleveland. Brought actually one of my favorite hats. I'm a Denverite now, but still a Brownies fan. But growing up in Cleveland gave me that, I think, that focus, the ability to focus on mission values. And so, the first business that I built was focused on keeping seniors at home versus going into long-term care facilities. Then I moved into the behavioral health space, focusing largely on individuals with developmental disabilities and specifically autism. Across that spectrum, across the entire universe, including Paladina now, I've focused really on trying to make companies more efficient, but trying to disrupt healthcare in areas of significant need. And so it's been gratifying to be in those spaces.
Interesting. Now, we're going to talk a variety of ways how you differentiate in the market, but some of that is the target population that you've chosen to focus on.
Yeah.
Why did you choose, and why don't you elaborate where primary care?
Yeah, so we've really presented a focus on the middle market, but we focus more on really the blue-collar workers, the institutions, municipalities, unions, teachers, and several reasons for that. One is because this is an area these folks really need help and need better care and better health care. So it's gratifying to be able to provide that to them. These individuals who work for these municipalities, teachers unions, et cetera, tend to be a little more sick than others and tend to have more aging populations. And so because of that, we can make a pretty dramatic impact on their lives by providing more access to their physicians, and we can get into more in terms of how we do that. But it turns out having great access to your primary care physician can be a huge determinant in terms of your health outcomes and cost savings. So we focus on that population there, and it's also a nice population to serve because they tend to have less turnover than some of the more high-tech focused companies that have individuals that turn over every 1 or 2 years. We love the idea of being able to treat a stable employee base and then therefore drive returns over the course of 2, 3, and 4 years. That's the secret to our success.
Okay. So hailing from Baltimore, Maryland, a blue-collar city, I'd like to thank you. And that's why we got most excited when we came time to invest in Paladina, too. I do want to shift tack a little bit because what else is interesting about the Paladina story is that it actually was operating in an established company, DaVita. Mm-hmm. And you were running the health capabilities, primary care for the DaVita patients.
Right.
Now, or employees, I should say. Now, what prompted you to want to seek outside capital and spin that out?
Yeah, great question. And so DaVita was a really strong partner for us and helped us to really start the business and start to grow it. But for us to really live our mission, values, and capabilities to truly disrupt healthcare in the United States, which is our vision, we needed a partner that would provide some greater resources and some connectivity. And so we did a fairly lengthy search. In agreement with the board of DaVita and my partners there, we agreed to divest the business, and we looked for the right partner for about a year. Wanted a partner that was really going to focus on both healthcare and technology and had that expertise, and so NEA emerged as the right candidate for us to sell 100% of the entity to, and then shortly thereafter we raised a significant amount of growth equity from NEA, Oak, Alta, Greenspring, and a few others. And so, look, it allows us to do some things that we couldn't have done within the confines of a large organization like DaVita, and they were great partners, but again, the level of connectivity, the ability to bring on a new executive team. We've hired 9 new executives in the last 9 months, given greater resources now, and are serving many more patients and impacting more lives than we ever would have before.
Yeah. So we hinted on the target population you guys focus on, mm-hmm. But tell me what's different if one of us were to walk in a Paladina Health clinic, what else is different that you've tried to offer to the culture or workflow?
Appreciate that. So it's really a new model of healthcare, and again, trying to disrupt the way primary care is evolving, but maintaining that focus of primary care as the gateway to better health. And so for us, it's really about access. Our patients have access to their physicians through an omni-channel approach, so 24/7 access through phone, text, portals, video visits, in-person visits as well. And so that access allows our patients to connect with their physicians, as much as they'd like. In addition, we provide blocks of 30, 60, or 90-minute appointments, and that extra time allows the patients to uncover a lot of health issues, and frankly allows us to work through a lot of preventive issues with those patients. And I'll tell you just a quick story to illustrate that. So we just had an individual who came in the Northwest with an infection on his finger. A mechanic came in. Normally in the fee-for-service world, You're talking about 7-minute appointments. The physician would have seen that individual, treated him for his infected finger, gave him some antibiotics, sent him out the door. And by the way, the antibiotics would have been picked up at a drugstore. We dispense pharmaceuticals on our sites. But because this gentleman had booked a 30-minute appointment, the physician got a chance to sit down with him and say, hey, look, okay, we treated the finger. Let's talk about your entire health, the whole view, holistic view. When's the last time you had colorectal screening? You're 50 years old. The gentleman said, never. I said, well, would you like to do that? Gentleman was resistant, but we convinced him to.
What's the definition of like?
Exactly. We convinced him to take his testing, and as it turns out, the test came back and he had stage 2 cancer.
Yeah.
Right? And so, but because we caught it early, they were able to treat it with surgery. He didn't need chemo, and the gentleman was back at work in 6 weeks. He's ecstatic because his life has been saved. The employee is ecstatic because they've saved a lot of costs as a result. And so it's that extra time connectivity with the physician that frankly is saving lives today that we offer. So it's pretty unique.
That's really helpful. I'm going to remind the audience that I have this tablet. Anytime you guys want to ask a question, I'm here, I'm ready. It doesn't have to be just my voice. I'm going to shift back to Dr. Myers, though, for a second or two. And one thing that's interesting now is the fee-to-service system is now changing over to the capitated bundled system.
Right.
I want to understand what you do to educate your physician base to get them ready for this huge evolution.
Yeah. What you're describing is that primary care has long suffered from medicine has long suffered, I think, from a service standpoint, from being so connected to the fee-for-service model, where the only way that you got paid for what you did was based on a transaction and basically a click. Healthcare in its best form is relational and not transactional. I think we would all agree on that. And to that end, we have been pursuing what are the ways that we could decouple the provision of care from a fee-for-service payment model. And we decided pretty quickly that one of the best ways that we could do that in the primary care space was to pursue what's called capitation, which is a prepayment model where for the folks that are in our impaneled lives that we take care of, and at the Cleveland Clinic it's about 700,000 lives in the primary care space or so, we have negotiated now with payers that instead of reimbursing us for each and every encounter, why don't we look at the historical spend that has been there in the primary care space and then pay us up front on a per member per month basis to care for those patients, with the goal being meeting their needs and optimizing the outcomes. And we've successfully done that. By the end of this year, about 50% or so of our compensation within the primary care space will be capitated. By the end of this next year, about 70% will be capitated. And what that allows us to do is to say, let's do the right thing for patients regardless of what that is, whether it's a house call, a video visit, a telephone call, a face-to-face visit of 20 minutes or an hour. Let's do the right thing for the patient regardless of whether it's directly compensable, because we're already effectively being paid for the care of those patients. And the physicians and teams are ecstatic about it because it really frees them up from that treadmill of fee-for-service and allows them the freedom to meet the patient's needs in the way that's best, rather than worried about what is the most fiscally responsible from the standpoint of the practice.
So two themes that both these gentlemen will try to aspire for is to lower costs and to improve patient outcomes.
Yes.
How do you measure that under this new system?
Well, patient outcomes are fairly easy to measure. I mean, there's some of the traditional ones, ACO measures, et cetera. One of the key measures that we're now embarking upon is patient activation. Yeah. And what the patient activation measure is, in other words, traditionally in healthcare, it's been somewhat of a passive sport, meaning that patients receive healthcare that we provide, and then they may or may not be particularly activated to do anything with that. Part of our job, responsibility, and opportunity in healthcare is to help activate people to be full-on participants in determining their own health, to be full participants in that process. And there are very validated measures where you can check and see how activated somebody is to participate in their health. So we're now measuring that on the before state and then seeking efforts and have different strategies about getting the buy-in from the patients that they need to actively participate in their own health care determination, and then measure the after state. So that's going to be one of our measures. Obviously, engagement, patient engagement, and patient satisfaction with the experience is important. But also, on the flip side, we're aware of the fact that physicians and healthcare providers are experiencing burnout now at significant levels, and we're not immune to that. And so part of redesigning the care is to bring more meaning back to the work. And we have very meaningful work in healthcare. I can't imagine more meaningful work than what we can have in healthcare. But the problem is we oftentimes dilute that with meaningless things and things that detract from that meaning and therefore detract from our own personal engagement with that effort. So we're trying to debride the process from some of those things and return more meaning. And then one of the things we're measuring is the engagement of the providers themselves.
That's interesting. Chris fed me a stat before we came here. It said, according to the national government, it's a 2-to-1 ratio, the number of hours spent on required documentation compared to hours of direct patient care for primary care doctors. So that connectivity to the patient really is an essential part, and not to be transactional.
And the team-based is very important. Back in 2009, there was a study out of North Carolina that took an average panel of 2,500 patients for primary care and said to implement the best practices in that panel of 2,500 patients for a solo physician would take 21.7 hours a day. 21.7 hours a day. And that was back before meaningful use and the computers became. That's pretty difficult to ever achieve, let alone sustain. So the only way to really effectuate the best practice in the care of patients is to redesign how it's done and to do that based on teams. And so that's why team-based care is so important to the redesign.
An important point. I'm going to flip over here to Chris. Same question about lowering costs, improving patient outcomes. How have you at Paladina kept track of how your patients are doing?
Yeah, much the same way. And so, look, the focus for us at Paladina is to try to provide the triple aim. And so we're working hard to provide better clinical outcomes. We're working hard to provide better patient and even client satisfaction and provider satisfaction as well. And then cost savings for our employers. As Dr. Myers mentioned, it's easier to measure the results of clinical outcomes, and we measure ourselves against the PPO 90th percentile, the HEDIS measurements, and because we have more time to spend with our patients, we do very well with those results. The patient and client and provider satisfactions are pretty easy to measure too. We typically use Net Promoter Scores, and we're very proud that our NPS score is 79, and that's in the world-class ratio along the lines of Trader Joe's and Ritz-Carlton and Apple and some of the best service providers out there. Typically, the highest scores in healthcare is here in the 30s, and so we're proud of those measurements. And then cost savings is really exciting and easier for us to measure too. We work with a client, and we can measure their healthcare spend before Paladina got involved, and then their total healthcare spend afterward, and we're saving our clients 10 to 25% annually across the board. But in addition, we continue to measure things too. We have a pretty robust analytics team that provides quarterly reports to all the clients that we serve on a monthly reports on a monthly and quarterly basis. And then we measure engagement, enrollment, activity, utilization of our physicians, and just making sure we're providing the best care as frequently as we possibly can to all the patients.
Well, we saw American Well right before us on a panel talking about the partnership they're going to have with Cleveland Clinic and use telemedicine to amplify what the Cleveland Clinic's doing. Analytics are sort of the table stakes at the moment. And for any new entrant into the primary care market. And Chris and I have seen firsthand some of the new entrants that have been funded by PE firms that are trying to land and expand and use telemedicine. But at the Cleveland Clinic, how do you use analytics to inform better workflow decision-making?
A couple of ways would come to mind. One, there are risk algorithms out there that help assign a level of risk to a given patient that would say, are they stable and healthy? Are they stable but have some rising risk that there's the potential because of a variety of different metrics that they then might decompensate or get less healthy? Or are they truly ill and then stable at truly ill, or are they unstable? And there were some existing third-party algorithms that were out there, and we evaluated those because we had interest about where to best focus our efforts from a population health standpoint. We found that those, as good as those were, they were not adequate. So within the Cleveland Clinic, we actually designed our own risk algorithm that incorporates about 125 different variables. Some of them are patient-entered pieces of data as well, and have found now that that correlates very well to the likelihood of decompensation for patients in the next 6 months. And we display that numerical score in the EMR on every patient that we care for, and it has a colorimetric change based on whether or not there's rising risk, and then you can click on that number and drill down to find which levers or variables directly contribute to the likelihood to decompensate, and then work to mitigate those risks. So that's one way that we've done it. Another way was with the ordering of labs prior to appointments. It's very helpful to sometimes, if you're going to be making a decision during an upcoming appointment about a patient's cholesterol or hyperlipidemia, to have a new result there to measure and make a decision on. Rather than having that process be manual as we had it, to where either physicians or MAs were having to go into the charts about 2 weeks in advance. We had 30 MAs doing this proactively, 30 MAs for our whole practice. We changed it to where it was algorithm-based and AI-enhanced, and one MA, as part of what they do, can every 2 weeks hit a button and produce what would be the likely orders based on those algorithms. And we were able to redeploy 29 different MAs to direct patient care rather than just combing the charts to see what needs to be presented and collect the information for the next visit. 29 people were able to be redeployed toward direct patient care, and our denials for labs went down by half because we were following appropriate algorithms. And so that's another way that AI and analytics have redesigned our workflow.
That's interesting. Chris, it's the same question applied to you. How are you using the analytics? And we've just put a massive investment into Salesforce recently that's personalized.
We have, and so what Salesforce and that investment's allowing us to do is a couple things. So one, it changes the way in which we engage with our patients and clients too, really. So it allows us to provide access through portals and through apps and through telemed, et cetera. And so it makes it much easier for our patients to access their physicians directly. But more importantly too, really what it helps us do is consolidate information from a lot of different sources. So we consolidate sources from the ER, from urgent care, from different specialists they may be seeing, which medicines they're utilizing, which labs they're utilizing, and we consolidate this into one 360-degree view that the physician gets every day. To your point, this used to be manually done, and we'd provide what we call a daily care opportunity for each of our physicians to say, hey, what should I focus on with the patient that I'm serving today? Now it's automated. And so this is much easier for our physicians, our MAs to utilize and say, okay, we've got this real-time data. Beyond that, we've got some rules engines that we're placing behind Salesforce that will allow us to do some neat things for each of our physicians to point out exactly what they need to focus on, and also allow us to do some predictive analytics.
Okay, thank you. We're now at about 7 minutes before we finish up, but before I keep asking questions, does anyone from the audience want to raise their hand and be daring? All right.
Correct. So the question that was asked, in case all of you couldn't hear it, was the typical healthcare is set to fix problems rather than prevent them. Part of the idea with redesign of primary care as well is to change from simply addressing acute needs and acute manifestations of chronic diseases and then move upstream. Move upstream to say, you know, if we were to address this factor or this factor in your health right now, and in your personal life, and in the social determinants of health surrounding your life, such as whether or not you have job security, food security, transportation, et cetera, those things, and then move upstream, we can then help you prevent these downstream consequences of those things not being aligned. So that is very clearly part of what we're doing in the primary care space and in this new redesign of healthcare.
Yeah, and let me build upon that. I think you said that well. And like, there's been lots of studies now that talk about 80% of the healthcare spend is on just fixing issues and not doing preventive work. That's really the crux of what we do at Paladina, is making sure those patients have 30, 60, 90-minute appointments that are focused on prevention. And we can dig in to say, hey, look, let's talk about behavioral health. This is something we haven't had in the past, and let's do depression screenings and even beyond. And because we can save a lot of downstream costs with preventive work, that's how we're measuring a lot of our cost savings to our clients. Akron Public Schools is a client of ours here in Northeast Ohio, and they just use their own actuarials to determine they saved $300,000 this year, largely on preventive work, right? And so it's having more time with those patients, especially those with chronic conditions, where we can prevent them from having multi-chronics, or even the healthy population from having a single chronic. And that's the work, I think, that our access is allowing.
Please.
Investing in technology is absolutely important. It's a must nowadays, but also investing in physician, shaping the culture of the physician is also important. What are some of the things that you've done to ensure that the physicians invest their time, invest their efforts in adopting this technology that you bought?
Is that directed towards one of us or either? Okay, yeah. So look, my chief medical officer is here today from Paladina, and I think we do a really good job of making sure the physicians are considered in every strategic decision that we make. You know, the crux of what we do is making sure we focus on that physician-client-patient relationship. And so we include them in all the decisions, and they were a big reason why we invested in Salesforce, given the technology that they'd be included in and how it interacts with our EMRs. So we have a physician panel that's led by Dr. Barker that is a key decision maker in terms of everything that we do each day. And then getting their buy-in to that technology flows down a little bit more easily if those leaders for each of our regions is bought in. And so trying to make sure they're included in those decisions is a key part of what we do.
I would echo that. Inclusion into the process is key. All too often, technological solutions are presented that were really designed outside of healthcare, and then healthcare has to then redesign the workflow to match the solution rather than vice versa. And so what we really do is we try to choose partnerships in the technology space that are willing to build things that enhance the workflow rather than obstruct it. Additionally, we also get physician input into each aspect of our care redesign. Mm-hmm. In fact, they are the leaders of the care redesign. From how we hold patient and family panels for input within each one of our primary care service areas. They're part of those panels to find out how are we doing, what do the patients and communities feel like they need. The physicians and providers are part of those panels and hear directly from the patients and families, to meeting with us and our IT colleagues and et cetera on how do we redesign the care. Will this actually be fruitful and helpful for you, or are we just imagining that it would be? So it's important to get their buy-in and input along the way, for sure.
So we're at 2.5 minutes, probably last question if the audience, anyone wants to. All right, the brave soul to my left.
With the innovation and digital medicine coming in and all these technology, we know that there is a huge challenge in terms of showing the economic impact of those innovations, or in terms of like the pricing of that innovation. What are some of the strategies that you have found are more promising on that base?
One way I would say would be applying the technology and the innovation into spaces where it can be very impactful. Let me give you an example. We have through our risk algorithm, we defined that we had about 4,000 very high-risk patients within our cohort of patients. And those 4,000 are multi-morbid patients with lots of different chronic diseases, tremendous medication burden, who are, for the most part, almost homebound, if not homebound. And it's very difficult and disruptive for them to get in to come and see us in the appointment. So we built a program where we're going into their homes with nurse practitioners and physicians in alternating months to see them in their homes and do extensive treatment. As good as that was, they're frail, they're elderly, and they're prone to decompensate quickly. I mean, just at the drop of a hat, one too many piece of bacon with breakfast, and they will build an extra sodium level in their body and maybe have difficulty breathing that day. And they would call and say, I can't breathe. Historically, we were left sending an ambulance to the patient's home, and they would come to the emergency room, their life would be disrupted, and even if they weren't admitted to the hospital, the expense was enormous. So what we did was instead hired our own paramedics. And we send them out to the home when these calls come in, not with an ambulance, but with a kit bag and an iPad. They go out to the home, assess the patient in the home, together with patient, family, and the electronic medical record, assess the situation, then dial up one of our physicians that we call virtualists, that what they do is provide virtual care. And then together, there's shared decision making, and we've found that we've been able to keep those patients at home where they want to be at much lower expense 80% of the time. 80% of the time. So if you focus your initial efforts on changing care in that way, where it's dramatically impactful to both outcomes and spend and satisfaction, I think the technology begins to pay for itself.
Do you want to interject, or do you feel?
No, I just add to that. And look,
Okay.
I think our model is innovative in that we're providing 30, 60, 90-minute appointments. Extra care provides a greater impact on health outcomes, et cetera. And telemed can be a solution for us, is a solution for us now to reach the more remote population, and that's something we're focusing on.
All right. Well, on behalf of Dr. Myers, the prodigal son, Chris Miller, he now can get back and get on the plane on time. So thank you all.
Thank you.
Great.